Good morning, everyone. Welcome back to another episode of Pathagonia. So today we're going to talk about a very high yield topic, tumors of the cervix. So the first category we have are squamous lesions. So in the cervix you can have squamous metaplasia, which is the process where glandular endocervical cells are replaced with squamous epithelium. The primary importance of this lesion is that it can closely resemble HSIL. So in contrast to SIL, or squamous intraepithelial lesion, metaplasia has uniform chromatin, has minimal nuclear contour irregularities, is more likely to have residual mucinous epithelium, and is P16 negative. So you can see here on the right, or on the left, we have glandular stuff turning into squamous, losing that mucin that you would see in the glandular mucosa. And the squamous epithelium has very light chromatin. It doesn't look like it's dysplastic, so this is a benign process and it's metaplasia, not dysplasia. However, another common thing we see in the cervix is dysplasia, or squamous intraepithelial lesions, or SIL, also known as cervical intraepithelial neoplasia. This is intraepithelial in situ or non-invasive squamous dysplasia that's caused from HPV infection. There are maturation abnormalities and or viral cytopathic changes. It's asymptomatic, detected by screening. It's on colposcopy. A squamous intraepithelial lesion may be aceto-white. And the first in this category is LSIL, so low-grade squamous intraepithelial lesion, LSIL or CIN1. This is a proliferation of hyperchromatic basal-like cells that extends no more than 1/3 of the way up the epithelium. The cells differentiate by gaining cytoplasm in the upper epithelium, and mitoses are confined to the lower zone. Many nuclei are hyperchromatic with irregular nuclear contours at all levels, but the high nuclear to cytoplasmic ratio cells are just at the bottom. And coilocytes, as shown here in this image on the left, are large superficial cells with perinuclear halos and large irregular racinoid nuclei. Sometimes they're binucleated or even multinucleated on cytology. And LSIL often spontaneously regresses, so it's just observed clinically with repeat cytology. This will be HPV-ish positive and P16 plus or minus, so it could stain or it may not. And a condyloma is grossly evident exophytic variant of LSIL, which is often composed of papillary fronds. And here's a good example of LSIL where we have the dysplasia and the atypia really confined to the lower 1/3 of the epithelium, whereas we have more maturation and more cytoplasm around the nuclei up top. And we have some cells that appear to be coilocytes. You could imagine if you did a pap smear and you saw this cell on a pap smear, it would be certainly larger than 3 times the size of an intermediate cell nucleus. Very large cells are common in low-grade dysplasia. Moving on. So as discussed, these are dysplasias caused by HPV. So HPV is the human papillomavirus. It's a sexually transmitted disease. Very common, up to 80% of women in the early 20s have HPV. The serotypes are 16 and 18 are high risk, most associated with HSIL or squamous cell carcinoma, and 6 and 11 are low risk, which are most associated with LSIL or condylomas. HPV usually infects the transition zone between the squamous and glandular mucosa, and HPV can infect the epithelium without integrating into the nucleus, creating LSIL or condyloma, with often transient, self-limited with natural regression. Or it can integrate where viral oncogene overexpression drives a clonal production of undifferentiated cells, causing HSIL, which is a precancerous with persistent infection. The HPV-associated oncoprotein E6 inactivates P53, and E7 inactivates RB1. So continuing with our discussion of squamous intraepithelial lesion, we have HSIL, or high-grade squamous intraepithelial lesion. So this is a proliferation of hyperchromatic basal-like cells that extend 2/3 of the way up, CIN2, or full thickness, CIN3 or CIS, of the epithelium. Cells at all levels have enlarged hyperchromatic nuclei with irregular nuclear contours and increased indice ratios. And you can see this full thickness dysplasia, very high nuclear to cytoplasmic ratio dysplastic cells, all the way through full thickness in the epithelium. There's little CIN2 to no CIN3 superficial maturation. So if you have a little bit of superficial maturation, which we may have here, though those appear to be potentially still dysplastic, then this could be CIN2, as it would be 2/3 of the epithelium. But if you have dysplasia all the way through, that would be CIN3. Mitoses are common at all levels, including atypical mitoses. Nucleoli are unusual in HSIL and raise the possibility of inadequately sampled invasive carcinoma, which would be P16 positive, or metaplasia, which would be P16 negative. Variants of no real clinical significance. You can have keratinizing, papillary, and thin HSIL, which would be considered less than 10 cells thick. And treatment, given the risk of progression to squamous cell carcinoma, it's often treated with a LEEP, laser ablation, cryotherapy, or surgical conization. So the important point of discussion is, when do we use P16 immunohistochemistry? It's easy at first to think that we would order it on all cases of cervical dysplasia, but it's actually only indicated in certain scenarios. So it's used as a surrogate marker of high-risk HPV infection. When the morphologic differential diagnosis is between HSIL, which would be P16 positive, and a mimic, such as squamous metaplasia. When it would also be used as a surrogate marker when you're considering a diagnosis of CIN2, which should be P16 positive, versus LSIL, which should be P16 negative, though not all the time. When there is disagreement between pathologists, you could potentially order a P16, and when there is a high risk for missed HSIL disease, such as in a case of a patient with HPV positivity. So here we'll see what P16 would look like if positive. So on the left we have P16 positivity, which shows this strong diffuse nuclear and cytoplasmic block positive staining along the basal layer going at least 1/3 the way up. And this on the right is P16 negative, weak or patchy. So anything but block positive would be called P16 negative. So when would P16 IHC not help? So when the biopsy is unequivocally LSIL, HSIL, or negative morphologically, there's really no need to get a P16. And when the differential diagnosis is between LSIL and negative, as both processes should be P16 negative. And just remember, P16 has no value outside of morphologic context. LSIL can be P16 positive. And P16 has a very good negative predictive value for HSIL. Moving on, you can also have squamous cell carcinoma, which is HPV-associated. This is an invasive epithelial tumor composed of squamous cells of varying degrees of differentiation. About 95% of cervical squamous cell carcinoma is HPV-associated, and most commonly caused by HPV type 16 or 18 and arise from HSIL. Worldwide, this is the 4th most common cancer in women, mostly in low-resource countries without cervical cancer screening programs such as Pap smears and the HPV vaccination. In the US, rates have dropped dramatically. And what you'll see histologically are infiltrating, angulated, irregularly sized and shaped nest with anastomosing cords and solid sheets, nuclear pleomorphism and increased mitoses, and often desmoplastic inflammatory stroma. It can be non-keratinizing, which is more common, or keratinizing. And for IHC, you're going to have overexpression of P16, which is an acceptable surrogate for HPV infection. And with invasion, you can see paradoxical maturation with increased cytoplasmic eosinophilia. There are multiple histologic patterns that have been described, and they do not impact treatment, including keratinizing versus non-keratinizing, basaloid, verrucous, papillary, and lymphoepithelioma-like. Treatment depends on stage, but it often involves chemoradiation, and tumor depth of invasion must be calculated for all stage 1 carcinomas, and this is measured from the base of the H-cell origin or nearest dysplastic epithelium if the site of origin is not apparent. And this is measured to the deepest point of invasion. And note, if tumors are severely ulcerated or largely exophytic, measuring depth of invasion may be hard or impossible. And here's a table just to compare invasive squamous cell carcinoma versus H-cell colonization of endocervical glands, which can be hard to tell. So invasive squamous cell carcinoma, you're going to have paradoxical maturation of cells from high indice ratio H-cell to invasive cells with more abundant eosinophilic cytoplasm, which could be shown here. This is an example of invasive squamous cell carcinoma. Whereas in H-cell in endocervical glands, you're not going to have paradoxical maturation. You're going to have the same cells throughout the lesion. In invasive squamous cell carcinoma, there is a stromal reaction present with edema and desmoplasia, which would not occur in H-cell. And you can review the rest of this chart, just kind of what you would expect to see between squamous cell carcinoma versus H-cell involving endocervical glands. And don't forget, there is squamous cell carcinoma that can be HPV-independent, which requires a negative P16 and molecular testing for HPV. And about 5% of squamous cell carcinomas of the cervix are HPV-independent. Frequently, there's a keratinizing type, but you can have any histologic pattern, and there's often advanced stage and poor prognosis. So some benign lesions. First up, we have a very common for surgical pathology sign-outs. You'll have endocervical polyps. So this is benign. It's the most common growth of the cervix with focal hyperplastic protrusions of benign endocervical glands and loose fibrous stroma, as shown here in this image. You can see kind of the polypoid structure, kind of this dilation or cystic dilation. They may have cystic change of the glands, as shown here, and there's frequently associated inflammation. May have surface squamous metaplasia, and you can have a Mullerian papilloma, which is rare but a cervical or upper vaginal lesion of children with branching fibrous papillae lined by a single layer of benign glandular epithelium. Another common entity is a Nabothian cyst. This is non-neoplastic, and it's usually incidental and asymptomatic. Endocervical gland dilation after outlet obstruction. And you're going to see grossly, as shown here on the right, these dilated cysts filled with this translucent mucoid material lined by a single layer of columnar mucinous endocervical epithelium, but it may be flattened due to atrophy. Another entity that can at first look kind of concerning, but it's benign, is microglandular hyperplasia, or MGH. This is benign, very common, usually occurs in premenopausal women. And you have these tightly packed glands or tubules lined by flattened to cuboidal cells with eosinophilic cytoplasm, sometimes a small mucin vacuole, and uniform small nuclei with rare mitoses. You can also have subnuclear vacuoles, and in florid cases you can have reticular or net-like or solid growth with increased atypia. There's no invasive growth, and it's often associated with a lot of inflammation, and P63 highlights a subset of the cells. Ki67 will be under 10%, and it's usually Vimentin negative and ER/PR positive. Another benign entity is Aria-Stella reaction, which is shown here. This is benign change usually seen during pregnancy with high levels of progestin. You're going to have glandular cells that are markedly enlarged with irregular hyperchromatic nuclei and abundant vacuolated cytoplasm. You'll have hobnail and papillary architecture with nuclear pseudostratification, and often only focal within the cervix you'll have this. It does not form a mass. The main importance is that it can be confused with clear cell carcinoma. In contrast though, This reactive condition lacks mitotic figures, does not form a mass, and is seen only during pregnancy. So you can be sure it's benign in those cases. Some more benign entities, we have tunnel clusters. So these are benign, common, and found incidentally. And you'll have these clusters of benign, lobular, arranged endocervical glands, often near the surface, that can be cystically dilated. You can also have endocervical glandular hyperplasia, which is both confined to the inner 1/3 to 1/2 of the cervical wall, with no mitoses or atypia. Lobular endocervical glandular hyperplasia is rare, and it's a proliferation of tightly packed small endocervical glands in a lobular pattern, resembling gastric pyloric gland epithelium surrounding a central cleft. There's going to be bland basal nuclei thought to be the precursor lesion to gastric type or minimal deviation adenocarcinoma. You can also have diffuse laminar endocervical glandular hyperplasia, which is rare, and it's a proliferation of tightly packed small to medium-sized endocervical glands with no lobular architecture but has a clearly defined base. You can have associated edema and chronic inflammation. And next category is tubal metaplasia. Another benign entity that is incidentally found. You'll have endocervical glandular epithelium replaced by tubal epithelium, which you know it's tubal because it's ciliated with the intercalated PEG cells. The main significance of tubal metaplasia is that it can be confused with AIS. However, tubal metaplasia shouldn't have any mitoses, and it has no significant atypia and should only be one cell layer thick. You can also have endometrioid or tuboendometrioid metaplasia with varying resemblance to normal endometrium. The next category are mesonephric remnants. These are benign vestigial embryologic remnants from the mesonephric duct, most common in the lateral aspect of the cervix, and they are small tubules or cysts deep within the wall of the cervix, often arranged in clusters. The tubules are lined by cuboidal cells that can have central characteristic PAS positive secretions as shown here. And for IHC, they will stain with GATA3, TTF1, PAX8, calretinin, and CD10, and they'll be P16 and ER negative. If there's a large collection, this is mesonephric hyperplasia, but it still maintains lobular growth throughout. Next up, we have HPV-associated adenocarcinomas. So first in this category is adenocarcinoma in situ, or AIS, which is HPV-associated. This is a non-invasive adenocarcinoma, so it's confined to the normal pre-existing glandular epithelium on the surface and in endocervical glands. It maintains lobular architecture, and it's caused by high-risk HPV, classically type 18, although also type 16. It's often nearby HSIL, and histologically you'll see cell crowding with pseudostratification, mucin depletion, and large nuclei with variable size and shape hyperchromasia, and sometimes large nucleoli, with floating apical mitoses, as shown here in this image, and they can be very atypical at times. You'll also classically have apoptotic debris or karyarexis. You can think of this as a highly proliferating, turning over area where you're going to have a lot of mitotic figures and karyorectic debris. And as far as IHC for AIS, it's going to be diffusely and strongly positive for P16 with loss of ER/PR, and Ki67 will be higher than adjacent normal endocervix. Some uncommon features are cribriform growth or goblet cells, although it can happen. And a unique variant of AIS is stratified mucin-producing intraepithelial lesion, or SMILE, which is stratified epithelium with nuclear atypia, hyperchromasia, and mitotic figures, and it has mucin vacuoles at all cell layers, as shown here. So you can also have adenocarcinoma, HPV-mediated, usual type. So this is an invasive adenocarcinoma of the cervix with relative mucin depletion, and it is HPV-mediated, so it's going to be P16 positive, and the most common type of endocervical adenocarcinoma by far. It often presents with vaginal bleeding and a mass, and it may be exophytic or ulcerated. Most tumors are well to moderately differentiated, cribiform to papillary architecture, with characteristic morphology, with mucin-poor glands and pseudostratification, enlarged hyperchromatic nuclei, and it must have less than 50% of cells with mucin. There is frequent floating mitotic figures and apoptoses, and some hints for invasion are beyond infiltrating growth, very complex architecture, haphazard growth, extension of glands beyond the depth of normal endocervical glands, stromal reaction, and other findings. For IHC, adenocarcinoma is going to be P16 block positive as it is HPV mediated. It's going to be PAX8 positive and HPV-ish positive. So some IHC to differentiate the location is endocervical is often P16 positive and ER/PR negative, Vimentin negative. However, if it's endometrial adenocarcinoma, it'll be ER/PR positive, Vimentin positive, cup-like, and P16 negative. And both can stain for PAX8. Next up, we've got mucinous carcinoma. This is HPV-associated and has a worse prognosis. Typical HPV morphology, so you have the floating mitoses with frequent apoptoses, but with more than 50% of the cells with intracytoplasmic mucin, as shown in this image. This often occurs in a background of usual type adenocarcinoma, and there are some subtypes of mucinous carcinoma, such as NOS, signet ring cell type, intestinal, and I-SMILE. So I-SMILE is invasive stratified mucin-producing intraepithelial lesion, which causes solid nests of stratified mucinous cells. All right, next up we've got villo-glandular carcinoma. This is well-differentiated variant of usual type, and it often occurs in young women with an exophytic surface component of papillae lined by epithelium that has only mild atypia. The papillae can be thin or thick, with similar staining pattern to usual type endocervical adenocarcinoma, such as P16 positivity. This, despite being villo-glandular, actually has an excellent prognosis. So, another thing to review on your own, I will go through some of it, are patterns of invasion. This is what's known as the Silva system. So there's Silva group A, B, and C, indicating low, middle, and high risk. So Silva group A are well-demarcated glands with rounded contours with no destructive stromal invasion. This may be hard to separate from AIS, but think AIS-like. So for Silva group B, and here's an example of Silva group A on the left. So kind of like AIS, very similar, you can think of it as that, with no destructive stromal invasion. Silva group B has localized, limited, or early destructive stromal invasion arising from pattern A glands, which are well-demarcated glands. So here we can see some stromal destruction or invasion, making this a Silva group B, which has a middle or medium risk with rare lymph node metastasis. And then Silva group C is going to have diffuse destructive stromal invasion, and this is a high risk entity with frequent lymph node metastasis. Moving on, so we have some HPV-independent adenocarcinomas. These are usually present at a later age than HPV-mediated. So the first of which is gastric type. So gastric type, you'll have infiltrating glands lined by cells with abundant pale to eosinophilic cytoplasm and distinct cell borders, or gastric phenotype. This is not related to high-risk HPV, and you'll have diffuse infiltration without a distinct mass of stroma with malignant cytologic features, round vesicular nuclei, often with prominent nucleoli. And the glands show marked variation in size or shape, and the tumor is usually deeply invasive, often with a desmoplastic response. The typical presentation is profuse, watery discharge and barrel-shaped cervix. And for IHC, you're going to have P16, which is usually negative, and P53 is sometimes mutated with loss of hormone receptor expression, and they often express PAX8, CK7, and C89. The prognosis is significantly worse than usual type adenocarcinoma, and you can have minimal deviation or adenoma malignum. This is the old name, so no longer recommended, but perhaps useful to know for historical purposes. There's highly differentiated form of gastric type adenocarcinoma with numerous deceptively bland glands, which often lack surrounding stromal desmoplasia, but are deeply invasive with haphazard distribution. For architectural abnormalities, you can have intraglandular papillary protrusions and irregular profiles, claw-like, and at least focally some glands display malignant cytologic features, vesicular nuclei with distinct prominent red nucleoli, and are associated with stromal desmoplasia. This is associated with Peutz-Jeghers syndrome and or STIC11 mutations with the putative precursor of LEGH. And here's some images of what the gastric type adenocarcinoma may look like. You can kind of appreciate, it kind of looks like foveolar epithelium or more gastric in appearance with some of that mucin that you're seeing. So next up we have clear cell carcinoma. This is not associated with high-risk HPV, but it is associated with DES exposure. So the cells are going to have abundant clear to granular eosinophilic cytoplasm. They're going to be large, hyperchromatic, pleomorphic nuclei, and you can have solid, tubulocystic, or papillary architecture with frequent hobnail appearance. For IHC, they're going to be positive for HNF1B and NAPSIN-A, but not all that specific. P16 can be plus or minus with P53 wild type and ER-PR negativity. Next up, we've got mesonephric carcinoma. These are rare and develop from mesonephric remnants. They're often located deep in the lateral cervical stroma, and they're characteristic glandular spaces with eosinophilic PASD positive secretions. There's variable architectural patterns, so tubular, papillary, etc. And there's often small, tightly packed glands with low cuboidal cells. The uniform nuclei with coarse or vesicular chromatin, and there's frequent nuclear grooves and conspicuous nucleoli with no mucinous or squamous differentiation. The frequent sarcomatous differentiation can also be seen in mesonephric carcinoma, and the IHC is similar to the mesonephric remnants, which express CK7, PAX8, TTF1, and GATA3, with apical CD10 and negativity for P16, HPV, ER, and PR. Mesonephric carcinoma frequently has a KRAS mutation. All right, moving on. So some other subtypes. You can have adenoid basal carcinoma, which is rare. It's HPV mediated, so it's often nearby a cyl or carcinoma, composed of small, well-differentiated, rounded nests of bland basaloid cells that have scant cytoplasm and kind of resemble basal cell carcinoma. This has a good prognosis with no metastatic potential, and it is non-mass forming, asymptomatic, and often found incidentally. You can also have endometrioid subtype, which is rare, but resembles uterine endometrioid adenocarcinoma, so you must consider secondary involvement versus metastasis, and it may also arise with or from endometriosis. And another subtype is adenosquamous carcinoma, which is rare, HPV mediated, and contains malignant squamous and glandular components. This must have gland formation and must arise or may arise from cyl or AIS, with similar behavior to usual type adenocarcinoma. Moving on, you can also have neuroendocrine tumors or carcinomas, and like Elsewhere, you use the same classification system as in the GI tract, so you can see the GI guide for more info, but you're going to grade and stage those with Ki67 expression, look at the mitotic rate, and that's going to help you get to see if it's well differentiated or poorly differentiated, etc. So you can also have cervical neuroendocrine tumors, or NETs, that are extremely rare. And neuroendocrine carcinomas in general may be seen in association with other in situ or invasive carcinomas. So this algorithm, rather than just reading through it, this is a cervical adenocarcinoma typing algorithm. I'm going to let you kind of review this on your own, but you can kind of follow it through. Like the first step would be, is there cytoplasmic mucin? If yes, you go down this way. If it's limited, you go here. Then you look at HPV positivity or negativity and some various IHCs, and that'll kind of let you land on the diagnoses that we've already discussed in this video. But it could be just a good review to quiz yourself and see, if the material that we've been discussing is sticking. And that was modified from the American Journal of Surgical Pathology, an article in 2018. Also, you can have, as previously discussed, we looked at various entities that are HPV positive or HPV negative. And from there, you can, of course, you want to consider HPV status. You can then look at morphology, and that'll narrow down your differential. So some of the HPV negative entities: gastric, clear cell, endometrioid, serous, mesonephric. And HPV positive, you can have usual type, mucinous, and viloglandular. So really a lot of this is just evaluating morphology, checking HPV status, and then using our IHC panels to help us narrow down what specific subtype we're dealing with and whether it's a primary, a secondary lesion, or some kind of metastasis or from a nearby organ. And here's another nice little chart. These are great to make flashcards from or just for a quick review. And they're just going to go over the various IHC expressions for endocervical adenocarcinoma usual type, gastric type, and then endometrioid carcinoma, as well as serous carcinoma from the cervix, or from the uterus, I apologize. So review those on your own, and be sure to refer to this if you have a case where you need to look that up. So the last category are non-epithelial mesenchymal lesions, the first of which is a rhabdomyoma. These are benign, non-recurring, with haphazardly arranged, interlacing, mature, bland-appearing rhabdomyoblasts with oval or tubular shape. You're going to have cytoplasmic striations with no mitoses or necrosis, and for IHC, they're going to be positive for desmin, myogenin, and myod1. Contrast that with rhabdomyosarcoma, which is a malignant tumor with skeletal muscle differentiation. Most commonly, it is the embryonal subtype, and these are going to be polypoid tumors of small, round, or spindled hyperchromatic cells. And subepithelial condensation causes this cambrium layer, as shown here, with variable skeletal muscle differentiation, or strap cells, or rhabdomyoblasts, with frequent cartilage nodules. And rhabdomyosarcomas are going to stain similar to the rhabdomyoma, with positivity for desmin, myogenin, and myod1. And the last two entities are blue nevus and leiomyoma. So for a blue nevus, this is a benign melanocytic lesion. Grossly, it appears as a blue or black flat nodule, often 2 to 3 millimeters, with markedly enlarged or elongated spindle cells in the submucosa. It's often heavily pigmented, dendritic projections, and it's often organized parallel to the surface. For IHC, it's positive for S100 and SOX10, and HPV-45, melon A, and mite-F. So all of our melanocytic markers. And then lastly, leiomyoma. So this is a benign tumor with smooth muscle differentiation, which can resemble uterine leiomyomas. They're well circumscribed with intersecting fascicles of spindled cells, and cigar-shaped nuclei. There are no significant mitoses, atypia, or necrosis, and you can also get a leiomyosarcoma in the cervical region. However, in a leiomyosarcoma, you would expect to see some mitoses, atypia, or necrosis. So that's it. We made it. Kind of a marathon, but we got through it, and we appreciate your support. I hope these videos are helping. I know they helped me to make them and review this material, but I hope you're also getting some benefit, and I hope you have a good day. Thanks.